Hello, my name is Dr. Paul Mayo. I work at North Shore University Hospital, LIJ, in the Northwell system in the New York City area. I'm also clinical professor of medicine at the Hofstra Northwell School of Medicine. Yoni.
My name is Jonathan Greenstein. I'm an assistant professor of medicine at the Rutgers, New Jersey Medical School in Newark, New Jersey, where I practice pulmonary, critical care, and sleep medicine.
Yoni, why are we here?
So we're here in Glenview, Illinois at the CHEST Global Headquarters because we are very passionate about critical care ultrasonography, and we want to help those clinicians who are interested in taking the next step from basic critical care ultrasonography to advanced critical care echocardiography.
The National Board of Echocardiography has set up a national level certification for advanced critical care echocardiography, also known as ACE, as in the Ace of Hearts. There will be an examination, a full high-stakes board exam that will be given in January 2019. In addition, there will be a requirement to demonstrate full capability in advanced critical care echo image set. And that's why we're here today.
Now we find that when clinicians are first learning the full ACE image set, it takes about 20 to 30 minutes for a single exam, but after several have been done, the full exam takes between 8 and 11 minutes.
Sometimes longer, sometimes shorter.
Yes.
And one of the main questions we receive when we're giving conferences on the matter, courses, is what is the full examination? And that's why we're here to demonstrate the full image set that would be required at a minimum for each examination that is carried out in order to demonstrate capability, correct?
Absolutely.
Yoni, you've now completed your candidate for ACE, and you've completed, last count I believe, between 99 and 100 full examinations over the course of your fellowship.
Yeah, you still keep holding on to that last one, but you got to give me credit. I have gotten my 100 full examinations.
And you've become an expert level scanner, in my opinion. I'm your supervisor. I review your studies. So why don't we go over to our model and go through the full exam, the purpose being that the candidate then has a benchmark. These are the images that I must collect as I'm setting up my portfolio, being a serious candidate for critical care echocardiography.
Great, let's
certification,
do it.
Correct? Okay.
Let's do it.
A word of caution that you want to have full mastery of goal-directed echocardiography before you undertake any training in ACE. You'd agree with that?
Absolutely.
Yoni, you're going to direct me through the entire examination in just one go, correct?
That's correct. We've learned that you need a lot of direction, so I'll be here right behind you to help.
Thank you for this. May I give a few introductory words here?
Sure, please.
Yeah, for example, the audience will notice that because I'm doing a full exam for training purposes, I am physically comfortable. The machine is well orientated. I'm sitting down because the uncomfortable scanner will always fail in good image quality. I'm also on the right side primarily because of camera angle, and as a caution, anybody who masters ACE must be able to be completely ambidextrous in their scanning skill. We happen to be on the right side because it's a practical issue. There are some other issues that sometimes come up. For example, the probe cord. Some people put it around their shoulder. It's a nice looking position here. On the other hand, in the ICU, we're worried that maybe that's a fomite, so others prefer to lay it on the bed and not on their body itself. A few other things. There's some controversy about how much gel to apply. Some would place a little bit here and on the probe itself. The problem with that approach is that you'll be doing the application multiple times. The true ACE expert says, I'm going to put enough gel on so I can do the entire examination without having to constantly reapply it. Yoni, please give me some direction here.
Yeah, so let's first show the learners probe manipulation and what the different movements are called.
And these are standard terms that have been developed by the cardiology community 40 years ago, and we use them in our work, correct?
Correct. And our experience has been that the terms are often misused, so we'll spend a moment here. So one of the first manipulations is to angle the probe.
This is angling, correct?
That's correct. The next manipulation will be tilting the probe, where you're tilting the tomographic plane.
Yep, along the axis of the tomographic plane.
And rotation, which is, as it sounds, turning the probe.
Without angling, moving, or tilting it at all, just rotating it, correct?
Correct. And finally, there are simple movements.
The physical movement of the probe is defined as moving.
And it's important now with the ACE exam to think about all of those probe manipulations separately as you're making your adjustments.
Okay. What should I do first?
So we're going to start first with the parasternal long axis view of the heart.
I'll set gain right here. And I think the depth is properly adjusted. And I've achieved a standard acceptable axis.
After we have achieved our initial view, we'll first start with some color Doppler. And we'll look for mitral regurgitation. And you'll notice that Dr. Mayo is working on appropriately sizing his Doppler sample box. And you want it to include the entire atria and also go over the mitral valve a little bit. And we don't see any evidence of mitral regurgitation here. He's next going to move the Doppler sample box to look for aortic insufficiency. And again, he's overlapping the aortic valve with the LVOT, and we don't see significant aortic insufficiency. After this, he's going to fire up the M mode capability, and he's going to do three different things. First, he's going to look along the left ventricle, where he's going to do an assessment of the LV size during diastole and during systole.
Notice that I've moved the probe a bit, and also I tilted it in order to achieve a better axis for M mode. You want the M mode line to be perpendicular to the ventricular walls as much as possible. So I'm trying to fight for that. That's a weakness of M mode. It's very much angle dependent. I'll activate it at this point.
And an accurate measurement here can be quite difficult in our intubated, mechanically ventilated patients. Sometimes it's simply not possible to get this perpendicular.
I'm required to make some measurements. I'm a little concerned that the M mode line might be a little bit low on the ventricle. You like it really at the papillary muscle level, but I'll show you how the measurements are made. We activate our measurement capability. I do not see the right ventricular wall very well, nor the right ventricular outflow tracts. Shall we start with the interventricular septum?
Yeah, let's start.
All right. And we would want to make it during diastole. You know, Yoni, I've noticed that we don't have a we don't seem to have a EKG on this patient. What's going on here?
We're functioning right now in the reality of a lot of American intensive care units where our resources do not afford us some of the bells and whistles that we would like. Luckily, for a lot of the advanced critical care echo examination, we can deduce what part of the cardiac cycle we're in. So here, you are making the assumption that the largest ventricular cavity is during diastole, and that's how you're basing your measurement, and I think that's quite accurate.
There's the septal distance. We'll then
press select.
Select, and now we have the ventricular cavity at end diastole, and we'll hit select. And then the inferior lateral wall, rather difficult to pick out here because we have a contribution from the papillary muscle. I'll put the pericardial interface here, and I'm looking for the most continuous, most angulated line, and I'll move my, I think this is a little bit high there. How do I change them back and forth? Yoni?
I don't think you have a good option to change it now.
Yeah, all right. So this would be a gross estimate.
So let's do the M-mode scan line through the mitral valve and the aortic valve while we're here.
All right, those are quite straightforward here. So here, I activate. I see normal movement of the mitral valve. And we have a especially important measurement to make here, which is called the EPSS.
Endpoint septal separation.
Right, and that is related to some extent to assessment of ventricular function. It's an indirect measurement. If the EPSS is greater than 10 millimeters, it supports the possibility of LV dysfunction. Here we have 6 millimeters, which is normal range. Okay, and then we'll make an estimate of left atrial size. Is that the next with M mode?
Yes.
Okay. And we would like to come through the aortic valve here, and we will turn on M mode, and we see opening and closure of the aortic valve, and we would measure the end-systolic sides of the left atrium, caliper on, and we go edge to edge by ASE definition, and we select, we drop that down. So that's normal range. We'll save that image. There are a lot of other things you can do with M mode. These are the basics. M mode in many ways is a generational issue. A lot of modern echo labs don't really use it any longer, but it has some interesting applications for detailed analysis of valve function and wall motion.
So from here, the next view that I like to go to is the right ventricular inflow view, which Dr. Mayo is going to obtain by angling the probe medially.
Okay, so this is the first view that the goal-directed echocardiographer is really not familiar with. I've angled in to look at the right side.
I'm wondering if a left lateral decubitus.
Yeah, let's ask Bryant if he could roll over a little bit this way, please. Thank you. Yeah, all right. Okay, good. Now I'm seated comfortably on the bed. I'll find that parasternal lung right away. It's easier to get. Then I'll angle inwards. Here we have the RV inflow view. Yoni, should I take the group for a tour?
Yes.
Okay, here's the right atrium, here is the IVC inflow, here is the tricuspid valve, and here is the right ventricle. And of course, the ACE expert always colors every valve to see if there's a regurgitation jet. Here, I don't pick one up, but if we saw one, it is mandatory then to measure the velocity
And I'm going to be a
across.
stickler, Dr.
Yeah.
Mayo, and I'm going to ask you to make a larger sample volume box. Because let's assume that there was a regurgitant jet. In order to better see it, we want to cover the entire atria.
Okay, so I'll make that a little larger. Is that good enough for Newark, New Jersey?
That is.
Yeah.
A little bit more stringent criteria than out there on Long Island. I must say.
Yeah, I know.
Can you fire up the continuous wave Doppler just to show?
Just to show, so we change it here, and if we saw a TR jet, we would place it down through the vena contracta, that's at the site of origin of the jet, and we would attempt to measure the tricuspid regurgitation velocity, from which we could derive an estimate of pulmonary systolic pressure, correct?
Correct.
We don't see any here.
Let's hit the Doppler button just to show them the
What it would
sweep
look?
and also
Sure.
the point to which direction the regurgitant velocity would
All
be.
right, so we would target it with color. We would then turn on CW, find the jet, which we don't have here, and you would like me to activate. And this is how this is what the tracing would look like. And if we had a jet, and we'll show those in a lot of the abnormal image sets that we're going to send over to chest, you would make the measurement very
And
easily.
it would be a negative velocity.
Negative
so it would be
velocity,
below
yeah.
the line, not above the line.
Okay. So, what is the next standard view for the ACE examination?
So we now move back to the parasternal short axis view, which our basic critical care echo colleagues will be familiar with. And the basic colleagues will be familiar with the midventricular, also known as papillary muscle level. So let's start there.
All right. So we rotate 90 degrees, and we'll start at papillary muscle level. Everyone is familiar because everyone who's interested in ACE has full capability at goal-directed echo. And then I would propose we do segmental wall motion abnormalities. We do septal kinetics. We then angle down to look at the apical segments. And then we start angling up to the mitral valve level, which would define the basal segments. And you can do a full segmental wall analysis with ACE capability simply by looking at those 3 levels, correct?
And we'll typically put color Doppler at this point.
Yeah, if you wish, we'd look for MR from a somewhat unusual level right here. Okay. All right, we then go to the base of the heart. And in the center of the screen, we examine the anatomy of the aortic valve. I do not have clear closure point, but I think this is a tri-leaflet valve. Morphologically, it's normal within the context of imperfect image quality. And then we would color this, just as we did with the parasternal long axis view of the aortic valve, to look for a regurg, which we do not see. Yoni, what's the next valve we should look at?
So let's look at the tricuspid valve, if you can bring it in.
So I tilt over to the tricuspid valve, and this will be over in this area. I'm going to try to scan through it. And whenever I see a valve, I will always put color on that valve to look for tricuspid regurg. If we saw it, which we don't, I would then place the CW line right through the origin of that jet, and I would turn on Doppler, I would freeze, I would make a measurement. The next, Yoni?
So next we're going to look for the pulmonic valve, which we see quite nicely on this view.
Yeah, so I'm tilting over to look a little towards the left, and I can see the pulmonic valve, which is right here.
Now we're going to look for some pulmonary insufficiency.
Okay, so I will then activate the color. Ah, look, there's a little bit. Look at that. Yeah, that's actually quite common in normals. It's a normal variant. So as soon as we see a color jet of any sort, we want to measure the velocity across that valve. I'm not sure we're going to pick it up, but let's give it a try. We're off angle, so this will be an underestimate of velocity, but I'll see if I can get a little bit of a signal here. Ah, in fact we do. I'll change scale. So I'm going to shift my, my probe angle a little bit to try to get a better Doppler angle. Here we have it. And Doppler, I'm going to try to find the origin of the jet. There we go. Activate. I don't think we're picking up the PR jet.
And I would point out that as critical care intensivists, we are interested in significant regurgitation jets.
Yeah, this is very
So that's
normal.
not something really worth spending our time trying to measure.
I'm now going to move the probe a little bit downwards, and I'm going to then angle up to try to find the pulmonary artery, the main pulmonary artery. Here it is, right here. And as soon as we see that, we're going to make a measurement of the acceleration time, correct?
That's correct.
All right. And we use PW for that. Yes?
Yeah, we're going to use
Okay.
pulse wave Doppler.
Yeah. I put the sample volume here in the main pulmonary artery. I activate. And I'll try to get a good view here. I had one for a moment. I'll try once more. Right here. Get a little closer to the valve. Right here, Doppler on. Yoni, what do you think?
So the image quality is not optimal, and this is where our transesophageal echo really wins the race for better imaging for this view.
We'll still show how to make the measurement. So the interval between the onset of the velocity envelope and its peak is 155 milliseconds, which indicates this patient does not have pulmonary arterial hypertension.
That's
correct? Okay. We'll take maybe a subcostal view if we can find it to make the same measurement. Okay.
Sure.
So does that pretty much complete the base examination?
So that completes the parasternal views.
Oh.
So we're now going to move to the apical four-chamber view of the heart. Our patient's already in a good left lateral decubitus position. If the patient was not in that position already, now is a good time, as it will dramatically improve your imaging quality for these more advanced measurements.
I think the depth, axis, and gain is acceptable here.
Maybe the near field gain we can turn down a touch.
Okay, okay. I'll drop to a 1 inch space more lateral to see if I can thin out the apex, but I don't know. Yeah, I think this is probably the best I can do right around there. I'm a little worried I'm a little foreshortening the apex, but more lateral I lose image quality. Is this all right for our purposes?
I think for teaching
purposes, yeah.
This is quite good.
And the goal-directed echocardiographer, of course, uses this primarily to size the RV to the LV, but now in ACE territory we make a lot of other different measurements, correct?
That's correct. So let's first start by doing simple colored Doppler to look for regurgitant jets.
Box size I'll maybe make a little bit smaller. Yeah?
Mm-hmm.
Okay.
We do not see mitral regurgitation, and now Dr. Mayo is going to move the box over to look for tricuspid regurgitation.
The audience will notice that I'm scanning through the valve by angling my tomographic plane. Valves are three-dimensional structures, of course, so it's important to do that. Over on the tricuspid side, likewise, I scan through the valve a bit. There's no TR and there's no MR. Nothing to measure there. Yep, you agree?
Correct. Yes.
Okay.
So we can now move on to our assessment of diastolic function. And we typically start by using pulse wave Doppler to measure mitral inflow.
We have to be very cautious here because Dr. Greenstein is first author on a major review article on diastolic function evaluation by the intensivist. I was in CHEST, I think either this month or last month. A good read, but again, he's an expert. What should I do?
So let's take the PW, okay, and you're going to place the sample volume box at the mitral valve leaflet tips within the left ventricle. And then you're going to hit Doppler again. And what we're looking at is the flow that's going towards the sample volume box, which is towards the probe. So we're looking at the velocities that are positive. Now, in an ideal world, we would have ECG leads attached, but we're functioning in a realistic, somewhat unideal world. Let's imagine that our single ECG lead has been stolen or lost by one of the medical residents in the hospital. And so we're going to make some assumptions that this patient has normal diastolic function. And what Dr. Mayo is doing is he is measuring the E wave, which is early mitral filling during diastole, and then he's measuring the A wave subsequently, and in between he's going to calculate the pressure half time.
Yeah, and this is an archaic measurement, except for very specialized applications. The decel time or the pressure half time rather will jump forward to the A wave, and that gives us an E to A ratio, correct?
Correct.
All right.
And it's beyond the scope of this series to go into this in more detail other than how to acquire the measurements.
Okay. And for full evaluation of diastolic dysfunction and for estimates of left atrial pressure, you're going to ask me to do what?
So we're now going to use pulse wave Doppler with tissue Doppler imaging, TDI, to measure the velocity of the mitral valve annulus. And we can measure either or both the lateral annulus or the septal annulus. So Dr. Mayo is just getting a workable image. you'll notice he's moving his pulse wave Doppler sample box, and he's turning tissue Doppler imaging on. And now what he's looking at is the velocity that's moving away from the probe, so the negative velocity. And just like inflow, there's an E, which is now called E prime, and an A, which is called A prime. He's going to measure those. And this is where ECG is really crucial and helpful, because right now it's a little bit difficult to tell which is which.
So we would go to main. We then go to the TDI selection. We're going to do a lateral E prime, correct?
Correct.
Now, I'm identifying this area as the systolic movement of the annulus. Therefore, this is the A prime and this is the E prime.
That's correct.
So 15.
And we would say that's how the gorilla critical care ultrasonographer figures things out.
Right. With EKG it would be a lot easier.
Yes.
And my conclusion here is that this patient has normal velocity of normal TDI velocity, lateral annulus. You could do the septal if you wanted to be complete. I don't think it's necessary. This is normal velocity, and that virtually excludes diastolic dysfunction. And the ratio of E to E prime would give you an estimate of left atrial pressure, which in this case will be normal range.
That's correct.
Okay, good. All right.
So from the apical 4-chamber view, we next go to the apical 5-chamber view, so that we can measure the velocity time integral over the left ventricular outflow tract as an estimate of cardiac output. So Dr. Mayo is going to use PW and turn off the tissue Doppler imaging. And he's going to adjust his sample line and his sweep speed to optimally image this velocity. Okay. And the flow is going from the LV over the LVOT away from the probe, and it's the velocity that is negative, that's below the line. And he's going to manually trace the curve.
And this will be directly proportional to the stroke volume. And if we knew the LVOT diameter, it would be a simple arithmetical calculation for stroke volume, correct?
That's correct. And the LVOT diameter is easily calculated at the parasternal long axis view of the heart.
Normal range is 18 to 22 centimeters.
That's correct.
Bryant is a normal subject. This is no surprise to us, correct?
And we're happy with the positioning of your sample box because we see aortic valve closure at the end of systole.
Mm-hmm. All right, as long as we're here, shall we take a quick look at right-sided function?
Sure.
In terms of measuring the TAPSE, that's what you like to do. What does that stand for, TAPSE?
So TAPSE stands for tricuspid annular plane systolic excursion. And it's a surrogate measure to help estimate how RV systolic function is. And what Dr. Mayo's done is he's turned M-mode imaging on, and he has passed the M-mode scan line through the lateral annulus of the tricuspid valve. And he's measuring the height difference between systole and diastole.
A normally functioning ventricle, on the right side, there'll be quite a bit of movement of the annulus. As we see here, it's 22 millimeters, and that is a normal movement, normal TAPSE, to no one's surprise, correct?
Correct.
Yeah, okay. All right. Next.
So we now move to image the ventricle and the valves in other orthogonal views. So we move from the apical 4-chamber to the apical 2-chamber view.
I rotate my probe 60 degrees to achieve a 2-chamber view.
And that was a counterclockwise rotation.
And for the ACE candidate who must know all 16 segments, there are actually 17 segments, but we'll say there are 16. This is the anterior wall, and this is the inferior wall. And then to continue the rotation to another 60 degrees, we have the 3-chamber view. This is the anterior septum, and this is the inferior lateral wall. If necessary, M mode can be, if necessary, color can be applied to these valves. In this case, we would not regard it as necessary. An alternative means of measuring the LVOT VTI is to measure it here, and that has the same implication as measured from the 5-chamber view, correct?
Now, you would agree that for the intensivist or clinician who is delving down the ACE path, it will be a required measurement to do. So there should be color Doppler done at all of these different angles for a complete image set.
Yeah, we would advise that. And you would measure VTI here, and let's see how does it compare. Yeah, so you always take the higher value because of the issues related to Doppler and angle of the insonation, correct?
Correct.
All right, normal range, great. All right, what's next?
So we now move to the subcostal long axis view of the heart.
All right, oh, okay, there we go. All right, I'm trying to adjust my probe position and also tomographic angle in order to show both ventricles as horizontal as possible on the screen. This is a familiar view to the goal-directed echocardiographer. You can, of course, if necessary, color these valves, particularly the tricuspid valve. Sometimes it offers a good angle for insonation for measurement of transvalvular velocity.
Now we like this view, the size for regurgitation, because we can also look at the IVC, which is something done in the basic exam.
All right.
And before we go there, let's do a short axis view of the left ventricle.
There we have something that's rather equivalent to the parasternal short axis view. And if you fail with parasternal short, then this is the bailout view to get the same information, obviously.
Right.
We then move the tomographic plane a little bit over towards the right, hoping to find the pulmonary artery. And I think we have a little bit of colonic gas up here that's blocking us a bit. So we may be unsuccessful. Here's some sort of air artifact. So I don't think we're going to be able to see the pulmonary artery, although I can just see it unraveling here. Let's see if we can make that Doppler measurement. Sometimes bad 2D image, you still get Doppler information. Let's see what we get here. Ah, there we have it. Yeah, look at that. What do you think?
Yeah.
Yeah, we got lucky. All right, so we'll go to calc, and we're going to make a measurement of acceleration time, which was 1:55 initially. Let's see what it is here. Okay, this is the main pulmonary artery velocity time integral. I place my initial cursor here, and peak is right around. So this is, I think, more accurate than the first one. You agree? Pretty good. It's
has a quicker upstroke.
Yeah, it's acceptable, although not perfect quality. The patient does not have pulmonary arterial hypertension, correct?
Correct.
All right.
And really the final view is to measure the hepatic vein inflow at the IVC. I
am not able to image the IVC as it comes into the right atrium, simply because we have air artifact, that is transverse colon, so we'll be unsuccessful in finding the inflow of the hepatic vein until such time that that gas moves through. However, we might get lucky by coming a little bit more lateral, and let's see, can we find something that can help us? Let's see, there's the IVC there, but I don't think, Yoni, you'll be disappointed. Why don't you show us some views that are not necessarily part of a full examination that you would show to a mentor, but they're interesting. How about showing us a MAPC and an S1 velocity of the lateral mitral annulus, which have been somewhat validated as indices that reflect LV function.
Sure.
With obvious limitations.
So you'll recall before that Dr. Mayo did TAPSE by putting the M-mode scan line out here. MAPC is going to be the mirror opposite, where we put the M-mode scan line out to the lateral annulus of the mitral valve. And then we hit M-mode again. and we let it sweep across the screen, and then we can do our same measurement. And so,
A peculiarity of this machine is that you think you're measuring the hypotenuse of a triangle, but in fact the number it gives you is the vertical distance. Okay, in this case it's
1.59 centimeters.
good, which is normal range for MAPC, which is always a little lower than the normal for TAPC. The principle here is that the higher the greater the movement of the mitral annulus, the more normal is the function of the heart. That applies during diastole. It also applies during systole. So could you measure here the distance moved, but you might also be able to measure the velocity of movement.
Yeah. So MAPC was done with M mode, and to measure the velocity, we place a pulse wave Doppler sample box over the same area, the lateral annulus of the mitral valve, and then we turn tissue Doppler imaging on. And I'm going to adjust the scale.
The other way. Let's see. More.
Okay.
Okay. Yeah.
This was good.
I think I sort of had better image quality.
Here we go again. He's always giving me a hard time.
I think that, yeah.
I think you need new glasses, maybe.
Yeah.
All right, let's.
Feedback.
For those of you who know Dr. Mayo well, you'll know he's often wearing his wife's glasses because he can't tell the difference.
I like that. That's okay.
Okay.
So we have the E prime and the A prime, and then we have the upward movement there on the screen. That's the S1, and we're able to measure velocity. And these are simple measurements that evaluate LV function. Are they fully validated for use in critical care? Not really, but they're interesting to make, and they will probably have some future application for us. Are there any other specialized measurements that are not quite necessary for full ACE examination but of interest? Do you want to try for pulmonary venous inflow?
Sure. This is probably my least favorite measurement to do.
And there's a reason for that the literature is very specific that with transthoracic echo, and I would say especially in the critically ill, it's very hard to get a good quality image. We'll try for it. A little deeper in there, maybe. That's right. Move it over now off to TDI.
Thank you.
See, I would put it, I think there's an inflow right here. Yeah.
Let me fix my angle.
Yeah. You can see there.
Right there.
Try that. All right, slow the sweep speed, change line. Change line position maybe, or yeah. And here we have, I think the quality image is actually acceptable. Without EKG, it's going to be very, very hard to interpret. So we'll say, I wish we had the EKG today, but there's an example that's actually obtainable. Transesophageal echocardiography gives really, really easy and good quality pulmonary venous inflow, but its application now is more limited than it was 10 years ago. It's not part of the standard assessment for diastolic function or LAP pressure estimates any longer. Correct, Yoni?
That's correct.
Okay. Yoni, I understand you have some expertise with transesophageal echocardiography?
I did.
Yeah, how many exams have you done?
I've done 33 examinations.
Yeah. Okay. According to European standards, you're nearly at the point of credible capability. For the audience, transesophageal image acquisition will not be a requirement, emphasis, not be a requirement for NBE certification process. That will likely be an add-on in 5 years or so when more units actually have probes. So don't worry about that.